So our slide review on today is going to be on benign epithelial lesions of the breast. Bit of a disclaimer, so following presentation has been recorded live with current trainees of varying levels of experience with the subject matter. At the time of this recording, none of the trainees, myself included, are specialists or experts in the material presented. The cases were not given to the trainees ahead of time, so all impressions are initial reactions to the tissue, location, and brief clinical information as requested. Comments and opinions contained in this video belong to the person conveying them at the time of this recording and do not represent the opinions or stances of either UHCMC or the Department of Pathology. Please be constructive in any comments concerning the trainees as they are still learning, and we want to encourage them to be inquisitive and engaged in their learning. Clinical information is a general guide and not associated with any particular case. The exact clinical information for the included cases is unknown. There are no follow-up stains and no additional slides available. This presentation and associated whole slide images are available on pathpresenter.net. This presentation is not a substitute for medical advice. Please consult your physician with any questions related to your health. If you are a physician, please conduct research to ensure you are utilizing the most up-to-date information to manage your patients. Okay, so with that, we'll get started. So the first thing we're going to look at is normal breast and metaplastic conditions.
So first we have a few cores of assuming breast tissue at low power. It's very eosinophilic, so probably not very cellular at this magnification. So we're going to move in on one of these cores and see what we have here. So we do see some ducts and some fat cells, but the whole general impression is very fibrous, I would say. Seems to be, you have some ducts here that seems to be a little squished or deformed to me.
Okay.
Let's see, we can check on another core. Is this representative of the entire specimen?
The entire specimen.
Okay.
So what do you think?
How old is this patient?
Well, let's say 40.
40.
First mammogram and biopsy.
Well,
Is anything jumping out at you or not really?
I mean, first impression seeing some of those like squished glands. If it was a younger patient, I would say fibroadenoma. I mean, it's benign lesion, but you know, 40-year-olds can also get fibroadenomas.
True.
But
So I guess my hint for you will be we're dealing mostly with epithelial lesions today. So then would we include fibroadenoma?
probably not.
Yeah. Probably because I can fit it in with other lesions at a later time, right? Okay, so if this is not fibroadenoma, then what else could this be? You can use your cheat sheet if you want. Are you voting me or Mingfei?
Yes.
Do you have any ideas?
So it doesn't look like to me like a FA, fibroadenoma, because it's not well circumscribed. The glands are kind of okay. I don't see proliferative glands. The only thing here is the fibrotic stroma or sclerotic stroma. Can we see this fibroadenomatous change?
Okay, so I wouldn't give you a fibroadenomatous change if I wasn't going to give you a fibroadenoma. So I think this is, you guys are thinking maybe a little too much that maybe I give you pathology.
So this is just a benign
what if I
breast?
give you normal?
Yeah,
Could
it
this
could
be normal breast?
It could be.
So the thing with this was kind of the only example they had that was more normal, but there is like small areas that have more of an increased lymphocytic focus. So you could argue like, okay, is this patient maybe a diabetic or maybe some resolving mastitis? But it's so mild. But this is pretty much what normal breast should look like.
Okay.
Okay. All right.
Very
I didn't think
fibrotic breast.
yeah, very dense breast, right? Sorry, I didn't think that I was trying to stump you guys with the first one. I guess I don't give you normal too often. Okay, so a little bit about this if you guys want to read more about the anatomy. I gave you the boundaries of the breast anatomically. And I know you guys are aware of like what a partial mastectomy is, where that's lumpectomy plus or minus skin, and mastectomy, whether they do simple, modified, radical, or radical. And then just some nice schematics to show you like how the ductals come down from the nipple, and then what a terminal duct lobular unit is. So, because for the longest time, at least to me, the TDLUs was kind of like this abstract idea of like, what does that even mean? And I think the schematic's really nice, and the example on the bottom right also, because it really shows you like the tree shape. Alright, and then this is just going over your normal epithelium, so you know you have the 2 cell layers. So you should have like cuboidal or columnar luminal epithelium, and then you have your myoepithelial layer underneath that sometimes gets squished. Depending on your view, you might not even really appreciate the myoepithelium, right? So kind of similar to when we're looking at prostate, looking for those basal cells. All our normal stains. Well, okay, we normally don't stain normal breast, but if you were so inclined, those are some of the stains that you could use. Okay? Alright, next case.
Alright. So here we have very dense stroma in the breast tissue.
Yep.
And also we have some glands here, which isn't that. Okay. So the glands looks okay. There's no UDH in the glands. So in the stroma it's pretty dense. It is mass forming a nodule on
Yes.
mammograph. Okay.
This is a nodule in a man.
Man. Okay.
Okay.
So we can see the VV collagenous stroma, and with this slate-like spaces, like
I see where you're
vessel-like
going,
spaces.
but don't go there. Remember, epithelial lesions.
Epithelial lesions.
Epithelial.
Epithelial lesions. No.
So this
So this is not patch.
That is a stroma.
patch is a component of this.
Yeah. So we have patch.
Okay, but does
Nodular
patch
patch.
give you a lesion?
Yeah, it can be. Patch can be nodular.
In a man?
I guess it's possible.
Okay,
Alright.
so if we think nodular lesions
Nodular.
that look pretty benign,
Okay.
really fibrous, in a man, you can see this in women too, but it's This is the most common lesion in men.
Gynecomastia?
Yeah. So this is a lesion that's been sitting around for a long time.
Okay.
So what happens when they sit around is that they get more and more hyalinized, you get more of that thick collagen, and of course because it's breast tissue, right, so they can have everything else that happens in breasts going on there.
Right.
But kind of what you're looking for is the cellularity always concentrates right around the ducts, and you have, early on you'll have a lot of ducts and a lot of cells, and as it goes on there's just less and less cells, more and more
Okay.
scarring basically.
Yeah. I feel for gynecomastia, the epithelial cells will be more proliferative. Like we see a lot of UDH in the
They
glands.
will be initially, but kind of as it starts burning itself out, you're going to see less and less of that proliferative look.
Okay.
Yeah.
All right. Makes
Often
sense.
they want them biopsied and taken out, like right now.
All right.
Yeah. So this is what it looks like when it's been sitting around for a while. So if you're going into peds, think infants, all the in utero estrogens. In adolescents, they often have bilateral lesions, and those can progress or regress over time. But obviously, like, these can be socially and emotionally distressing to patients, so they typically want them biopsied or taken out. You can see this in women as well, but it tends to be really focal, and when we see it in women, we call it gynecomastoid hyperplasia. So I think most of the cases that you were talking about, where you were like, hey, I kind of see more UDH, that's more the florid or acute, so that's like the first 6-8 months. And then they start getting more fibrosis, and when they've had it for over a year, then we get that really fibrotic look. Okay, and pretty much what should you not see? Well, you shouldn't see anything that's scary, so we shouldn't see complex architecture, necrosis, and these lesions aren't associated with calcifications. So I think in the inset, that's a little more what you're used to seeing with gynecomastia, and then this looks more like the case that we had, where they're a little more on the fibrotic end. Okay, and because a lot of these tend to occur in males, so that's where we'd be thinking, okay, is this prostate? So doing your stains for prostate. And they can either cut them out or they can do hormone therapy, so things like tamoxifen. And they're benign lesions, but they can recur. So if they decided to do an excision and they didn't get the full thing, then it can recur, or if they didn't take the full course of tamoxifen. Excellent. Okay, so cystic lesions.
There's a tissue, some ducts, very fibrous stroma.
And there is one lesion for you to look at.
It's not this thing, is it?
No, that's normal.
Yeah, that's good. That's good.
Yeah, it's a lot of ducts kind of back to back.
Yeah.
Doesn't really seem to have a pattern. It seems to be a little haphazard, I would say.
Okay. Yeah, I'm pretty squished in there.
And looking at the cells,
how about the cytoplasm?
It's a little clear.
Okay.
Seems like.
I'm trying to see. Is that the highest power I'm gonna let you zoom in on?
Mm-hmm.
Okay. It's a little clearer on the computer screen. Want to make one out there?
It's not really projecting.
Yeah. So there's some prominent nucleoli. It'll be easier when you guys are able to go back and review these cases.
It's the same microglandular adenosis.
Pull back a little bit. Okay. So MGA would be one of the things you could think of with this. But the cytoplasm is kind of what helps you. It would help if there were more secretions in the lumina.
Galactorrhea.
Sorry?
Galactorrhea.
You're very close, very close. Okay, so, all right, we have, let's say, a 24-year-old female, and she is first trimester and feels a mass.
Just gestational change of the breast.
Yeah, lactational change.
Lactation.
Yeah, so I have a couple pictures in your guys' handout about lactational change and some of the things you can see in early pregnancy. So this is kind of where we have like, it's more vacuolated. It's maybe not the best fixation because it's kind of falling apart. But you'll see when we go to MGA, that's a hint, how it looks a little different.
It has a papilloma impression for me when I first look at it.
Yeah.
So this is like a whole lobule unit, right?
Yeah, so what happens is because of all the hormones, the glands kind of go crazy and they start proliferating and they get all this secretory change and they plump up with all these secretions. And like you can get full out nodules that are just, you know, what we call lactational adenomas. And then, so if you had a patient who had been breastfeeding and is no longer breastfeeding, then what happens is as this involutes, you see a lot more lymphocytic infiltration. So that again can make it, you kind of worried, like, am I looking at a microglandular adenosis, or even like some lymphocytic lesion? But this is
Diabetic there's a disease called diabetic mammopathy or something like lymphocytic infiltration around.
yeah. Oh yeah, yeah.
globules.
I know what you're talking about. Yeah,
What's the
in
name for that?
diabetics.
Diabetic mammopathy, or I don't know.
Yeah, it's like diabetic lymphoma.
Yeah,
Yeah.
looks
Yeah.
similar to this.
But so that's what this looks like,
Mhm.
and I know, like, the few times I've actually seen this where it wasn't like the entire lesion looked like this, I was like, is this invasive carcinoma? Because it kind of gives you that picture, right? So I think there's a little more over
Yeah,
here,
right.
but that's kind of what they look like. It's just still like not great secretions in there, but it's just, yeah, they're so plump that they're like coming off the wall. That's kind of what you're looking for. And then those are just regular lobules. You good? Okay, so no fancy outlines, just a little bit of pictures. So you can kind of be looking for more of the eosinophilic stuff. But yeah, they're generally just kind of crazy looking and very scary. Okay.
It's a busy slide.
It is a busy slide, yes.
So we have some dilated ducts with apical snouts. So this is good for a columnar cell change. Oh yeah. I'm wondering about FEA, but this looks okay.
Ah, okay.
It's kind of round.
Sure.
Okay, but I don't see much cellular tibia here.
Okay.
Yeah, and there are multi-layer of cells somewhere here.
There are some. That looks more regular though.
Yeah. So here I think is good for columnar cell change.
Okay.
Alright, search around. Look at normal lobules. There's more normal lobules. Yep, here's more columnar cell change. Are we expect to see more than this or
I think there's more.
more? Okay.
Okay.
Maybe some columnar cell hyperplasia, like since there's some multiple layer of cells. Maybe. I don't know, it's all the same. Some are dilated ducts.
Okay.
I don't see much in there. Just zoom out.
So what are we hunting for? What do we have?
Here,
Yeah?
we have a lot of lymphocytic infiltration.
Epithelial.
Oh, epithelial. Oh, here we have the TPI.
Yeah. What do you want to call that?
Huh?
What do you want to call that?
FEA.
I really like that.
Yeah.
I really like
this
that.
Is FEA.
Yeah. But this is a nice case because it has like even here you have a little bit of like apocrine, neoplasia. There's lots of columnar cell change, but a little bit of FEA.
Hmm.
Yeah.
Are they supposed to induce this inflammatory response? It's really drastic.
So yeah, there is inflammation, but at least in like this one, this is too much. That one looks too much.
Yeah.
I think like so
This is
FEA is in like this spectrum where you know like some people want to call a lot, but the really FEA when you're looking at it, is it FEA versus do we have maybe we're going into some ADH, but we don't have enough yet.
Yeah.
So it's everything's in this spectrum.
Okay.
Okay. But pretty much, yeah, I just kind of wanted you guys to see the change from columnar cell to FEA, because they're like the same thing. It's just whether or not you have atypia, and so you go from columnar cell change, which should really be extremely regular, like the top left. Those are both columnar cell change versus the bottom, which is FEA. So you can see like there's a definite difference. But when you start losing that polarity, you start seeing more nucleoli, and it looks more basophilic, like what that case was looking like. You should be thinking of that. Because here, so we have, again, up on top, we have columnar cell change. On the bottom, we have FEA. And so you can see some calcium crystals, right? And in columnar cell hyperplasia, pretty much you shouldn't really have atypia, but it's just instead of, focal stratification, you're going to have a lot more, and they can be heaped sometime, but they're still going to maintain polarity, and they're not going to be very pleomorphic. What else? Most of these lesions have the same 5 to 7% lifetime risk of invasive breast carcinoma. CCC, so it tends to have this 16q loss, which is the most common. But you can see like there's a lot of other cytogenetics that go on there, and I mean some of those associated with our low-grade lesions. If you want to do stains, these are going to be diffusely ER positive, and only your low molecular weight keratins.
So CCC and UDH, which is more advanced lesion?
So,
Let me see this here.
so CCC is more of like a reactive change, whereas UDH is a proliferative change. So, I mean, they're kind of in the same ballpark if you're looking at lesions that way, because like UDH being the most benign out of our proliferative ductal lesions, and CCC being the most benign out of those epithelial changes.
I think it's like 2 times worse, isn't it?
So yeah, 5 to 7% is like 1.5 to 2 times lifetime risk. It's like, well, whether you're looking at lifetime versus relative. So I tried to put them all at lifetime risk because some of them just wanted to give me relative.
Okay.
It's not the same as UDH.
Yeah. So, and almost all of them are the same. It's when we start getting into atypia that risk goes up. Yeah.
We have breast tissue here. There's some lobules. There's some area that could be just lymphocytes, or if it's 2 lobules, it's gonna look really weird. So we'll see once we zoom in on it. But first, just do a quick overview of the entire slide. So we have fatty tissues, fibrotic, more fibrostroma, and we're going to take a look at some of these more benign looking glands. So they're in nice little units there. Doesn't look too concerning. So I'm going to just do a quick overview of that. And then that one is a little dilated, but over here, whoa, what do we see here? This doesn't look normal, does it? Not quite, compared to the normals that we would see in this one, for instance. Those ones look a little more, to me at least, disorganized, a little more crowded. They're not really forming. Maybe it's the cut, but they look kind of, I guess it could be a terminal lobule here, but I don't know. It looks kind of funny, the shape, the architecture. Over here, oh yeah, this one's
Okay.
better. There's these, eosinophilic secretions in the center of these.
Yes.
So this one, I'm pretty sure is the microglandular adenosis.
Yeah, so you see how this one looks terrifying? So this lesion is commonly misconstrued for invasive cancer, and you can see why.
Yeah. This faded area looks a little concerning at low power.
Yeah. The kind of neat thing about microglandular adenosis, though, is that no matter how it looks, you don't really get much stromal effect.
There's no real desmoplassia.
Yeah, you're not going to have desmoplassia. You're not really even going to see inflammation with it. It's just very bland, but it's there. It's just going to trickle through everything. But you honed in on the eosinophilic secretions, because that's one of the things that does help you. And that's kind of it. Like, I think this is a pretty classic case. Like, you can see things like chondroid metaplasia, but often these things are just presenting for incidental findings. If they're very indurated, they could be biopsied or excised for a mass lesion. But so what you need to do, though, is if you see this on biopsy, or let's say a lumpectomy, and it wasn't entirely submitted, you have to go back and submit the rest of this.
So this is a benign lesion,
It is benign.
but it's
Yes.
negative for malpacilla cells.
Exactly.
Weird.
Yeah. So, so the caveat to that is that even though it doesn't have a myoepithelial layer, the basement membrane is intact.
Oh yeah. So that's
So-
stain of collagen, right?
Right. So exactly, if you did a collagen stain, which you don't have to do, but if you did a collagen stain, that would be positive.
Mm.
But yeah, so that's your microglandular adenosis. It's a good thing it's very rare,
Yeah,
right?
I've never seen this.
Yeah, it's very, very rare. Let's see what else I have for you guys. We went through a lot of this. Okay, so yeah, you have to report if present. So they kind of want to know how much is there, like if it's on a margin, right? They're going to have to go back. If there's atypical features or the AMGA for a typical microglandular adenosis. And molecular, not really helpful, unless if you're worried about atypia and you started seeing those abnormalities. But it should be definite atypia, like not just reactive or low grade. So what you can see in here, so we have you have your black arrows are your normal glands, and then the blue arrows are pointing towards the MGA. So you can see how it just trickles in there and can make life very confusing. And then we have an inset of that eosinophilic material, but it was pretty much everywhere on that slide, so that was really nice. And no one really knows how well they do or don't do because they are really rare. So they, as far as we know, they don't metastasize and they don't progress, but we might be completely wrong about that.
Okay.
Okay?
Alright. This is a very busy slide as well. See a lot of fibrosis around the lobules. If these are lobules.
I noticed in our set, like all the breasts are much more fibrotic than we usually see them.
Yeah. Yeah, I don't know if like a lot of these lesions came from younger women or like they just had really dense breasts.
Yeah.
Guys, stop there. Stop there. This is what I want you to look at.
Yeah, this the microcyst.
Save you.
This is a microcyst.
Okay.
Maybe some chromosome change.
Uh-huh.
What else? So we're only discussing epithelial lesions today, right?
Only epithelial lesions. The only one that kind of snuck in a little bit was the gynecomastia, but I was like, it doesn't really fit in anywhere really good, and there's so many things that we want to try and cover.
Yeah. So this can be microglandular adenosis or adenosis. We just see a lot of proliferation of the small glands, the ducts, and with the very fibrotic stroma, so sclerosing adenosis could be one possibility.
I mean, that could be artifact, but there could be some eosinophilic
This
things
is
in
what
there.
I want you. What is this? You called it a microcyst and left. It's not a microcyst.
Is this, you mean a big cyst?
What's in this?
It's milk.
cyst?
What's in it?
It's milk, right?
Yeah, so what do we call those lesions on biopsy? This is a biopsy.
I don't know, milk cyst.
You're very close, yeah.
Mucocele.
Yeah, so we call these mucocele-like lesions because we can't tell, like, hey, is there maybe a mucinous carcinoma sitting around? Like, if you had obvious atypia, then that you could call a carcinoma. But if you just have things like this where it's like they're just kind of filled with mucin and their stain maybe isn't the best.
Oh.
But sometimes, like, you can even see, like, there's a little bit traipsing out in some areas of the slide where there's some mucin that's extravasated a bit. I don't remember if there were other spots on the slide.
So how would you tell the difference between this and, let's say, a microcyst or something? Like
So, microcysts are cystic, and okay, bad explanation. They are cystic, but so you're not going to have the mucin. Definitely no extravasation of mucin. And maybe just low power. You guys like to zoom in so much. Low power, low power. Just look at this, look at this. You see how it's kind of everywhere? Like when you have that much mucin, there's no way that this is just a cyst. Like you see how it's over this way. Like all this.
Okay, yeah, I can see that one.
Okay.
Yeah.
And sometimes they have like these little like micropapillary or papillary projections.
Yeah, this one you can see it's kind
Yeah.
of oddly shaped.
Yeah, and you can see how it's kind of falling apart. So these are MUCOCELE-like lesions. Yeah, so they're just a little different.
I guess
The
the
epithelium's kind of a little more revved up, like a little more hobnaily, I guess. But if they get really big, they can be attenuated too. So.
Because the mucus is just not really projecting on this.
No, it's not, and it is kind of more of like a flocculent eosinophilic. But like this general picture, like this is not microcyst, so you want to think mucoceles, okay? And just so that they go back in, they take it out, so you can actually classify the lesion. Mm-hmm. Yeah.
It's very uncommon, I guess. Yeah.
Very uncommon. Yeah, well, these things are uncommon, right? So that probably means next week we'll see a few of them floating around. But there's not too much to say about them because you can't really go beyond saying it's a mucocele-like lesion. Like I said, unless you had frank atypia to the point that you can call carcinoma. Because all these lesions are going to look very similar on biopsy. So that's why you hedge and say mucocele-like lesion. If you want to do mucicarmine or any mucin stain, that's going to be diffusely positive. I guess the mucin is a little more eosinophilic in those pictures too, and those are ExpertPath pictures. So yeah, the ones that I've seen, it's been like seas of mucin where you have very little cellularity, and like from what I've seen, that's been a little more common, and probably because they do these teeny weeny little biopsies now. So you don't tend to get a lot of cells, so then you definitely want to hedge unless, again, you have, obvious pleomorphism. But yeah, if it's just a mucocele, then those are benign, but obviously even if it's an invasive mucinous carcinoma, those are low grade. Okay. Sclerosing lesions.
Okay. We're blessed again with a concentration of ducts in the center here. At low power, it doesn't look normal since we have too many of them. So let's zoom in. Incidental finding.
Some aprichensis.
Sorry?
Just some aprichensis.
Yeah.
Yeah.
Over here. So these ducts are way too many.
Mm-hmm.
And some of them are a little dilated. Just the general picture is just it's very ductily.
I like that, yeah.
And the background stroma doesn't seem to be really reacting, but it is fibrotic.
Uh-huh.
Yeah, but there's no reaction, so I'm not concerned for any malignant process here.
Okay.
Even though at low power, initial thought would be like, well, what is this thing? But I would still say this is benign, and there's an increasing amount of these sort of glands, so it's an adenosis of some sort, I would say.
Okay.
And
So these ones down here are beautiful examples, so just low power. Look at the overall architecture. And so if this is your center point, how does everything else look in relation to that? Again, easiest to see at low power.
It's like radiating.
Kind of radiating, kind of swirling
Okay.
around it. I think those are like this one and the one right at the bottom, those are the best examples of it probably on this slide. That's something that kind of helps you out.
I say this is probably sclerosing diagnosis.
Okay. Like, do we sense hesitation? So, okay, so now you guys can high power. I know you want to.
I'm just
Kind of
checking.
blurry.
Yeah, it's a little blurry, but just checking on the ductal cells, like the epithelial cells, to make sure there's no like atypia or anything. It looks pretty benign. They're all roughly the same size, no real polymorphism,
Yeah.
mitotic figures, etc. So it confirms our benign. sort of
Okay.
thing.
All right. So still think sclerosing adenosis?
I put it. It's not. I mean, it's a sclerotic lesion, and I really don't see anything from this at least that looks like a radial scar. So
Okay.
it's just.
So here I want to call this papilloma.
It's starting to look a little. Yeah, but I think they're more. Yeah.
We're not doing papillary lesions today either.
It just looks so
It's good to think of
papillomatous.
it though.
It does start to have that look. Yeah.
Yeah, but for radial scar, I don't see a very good scar center.
Right.
Yeah.
Elastofibrotic scar center. I don't see that. I mean, I agree this is adenosis.
Sclerosing adenosis.
Yeah, sclerosing adenosis.
We just went over MGA and there's regular adenosis too. Okay, so this is sclerosing adenosis.
Yeah.
So frequently encountered. So when we say 12% of breast biopsies, that means that 12% where this would be the worst diagnosis on the biopsy. Because obviously if you see it with invasive carcinoma, the invasive carcinoma is going to trump the sclerosing adenosis. Okay, if they have a palpable lesion with sclerosing adenosis, these tend to be painful or tender. So that's something to keep in mind because a lot of these lesions, it's like there might be something palpable but not necessarily painful. Rarely they're associated with calcifications, so we know that would give us a gritty sensation when we cut into them. Okay, and so sclerosing adenosis, I think, is somewhat similar to our, in my mind, visually, the lactational change, because you have so much crowding, they start to mold on each other, but they're still trying to dilate a bit. And what can happen with them is that as they start to hyalinize over time, is that they start squishing those glands. So you might see areas where it looks like you have cords of cells, so that, or angulated glands, and that can make us really worried. So this is a very good mimic for invasive carcinoma. But what helps you with all of that is that there still shouldn't be any atypia, and your myoepithelium is still going to be present. But because of how they squish, you want to go to the outside of the lesion. And if it didn't get terrifying enough, you have to be worried about what's called pseudoperineural invasion, which does happen with sclerosing adenosis. So this is where the glands start involving the nerves. So that's why I have on the far right. So you can see that big nerve bundle, and you have glands all the way around it, right? That's scary. And then if you do your P63, looking for those myoepithelial cells, it's going to highlight around that, and then you can breathe again and know that you just have sclerosing adenosis. And the nice thing about the P63 on the left is the comparison between the microglandular adenosis. So even though they're both adenosis, that helps. Yeah. This is a very nice example of nodular sclerosing adenosis, which is what that case is. And that just portends to the overall architecture.
Yeah. It's generally well circumscribed. That's how I feel sometimes.
Yeah. Well circumscribed but terrifying at the same time. Yeah. Okay, and we see again there's that 5 to 7% lifetime risk, right? So if this was all they had on their lesions, like they don't got to do anything else, just a regular annual screening if they're over 40, or per their recommendations for family history, personal history, etc. Because you guys learned all about that last week.
Another one of those.
Another one of those, okay. Well, I wouldn't trick you like that. I promise this one is a little different.
I mean, there's a lot of small glands.
There are. Again, this is one that you want to look at low power.
Yeah, I mean,
If you squint, you can sort of see maybe a pattern.
yeah, that's probably good for a scar.
What do you think? Is that good enough?
Yeah, I
Maybe?
think this one starting to be a radial scar.
It's good, but not the best.
It's not the
Yeah.
best. It's the best that I saw, but I do try to give you guys the best slide.
Yeah, I mean,
And-
usually it should be lustofibrosis.
It
This is
should.
bluish color.
It should. But what if this is long-standing? Well, if we have a, okay, let's play a little what if. So what if we had a patient who's 72 years old, has never had a mammogram, and comes in complaining, oh yeah, you know, well, I got this cough, and they're doing a general exam, and they notice this lesion. Which would probably be how something like this would occur, where it's very hyalinized. It's probably been there a good while.
Yeah.
But I agree, it's such a busy slide that it makes it difficult to kind of focus where you need to.
Yeah. So
Okay.
what's that triad for radial scar, like ALH?
So you can kind of see anything in
Anything.
a radial scar, but probably what you're thinking of is there ADH, ALH, or, I mean, because you can also see in situ, you can see
CIS.
invasive,
Yeah, right.
yeah.
Here's like adenosis.
Yeah, there's a lot of adenosis in this, I think.
Yeah, adenosis.
Yeah.
Maybe like ALH or not. No, it is not ALH.
Yeah, not really expanding.
Yeah. I was never able to diagnose a radial scar in
They're
real
hard.
practice.
And usually we get these tiny little biopsies where it's like, well, is this just sclerosing adenosis? Is it a fibroadenoma? Is it a radial scar? So these lesions are very difficult, and
It's best seen on lumpectomies. It's really
Yeah.
sucks, we get more tissue.
yeah,
I'm just
they
wondering what's the
definitely are.
biology for this? Is there like a trauma here, so that's why it starts to
So-
be like this, or?
Well, so radial scars are not associated with trauma or surgery. And yeah, it's not the best, but you have a little bit of dilation that's really close to the scar, and it does start to radiate off, and that's kind of what you're looking for, are these rays of the epithelial components that are coming off of it.
Yeah,
And that's what
here's
gives you
the
the
good-
star-like, Appearance?
Radiating out.
Yeah. yeah,
Dilation as well, yeah, sure.
yeah, a little bit, but usually like you see a lot more. But I definitely understand what you're saying, because I know I've seen cases where it's like, really, that's a radial scar? I'm not seeing the centralitis, or,
No.
but I think on lumpectomies they're easier. Okay, so this is kind of what we were looking for, right? So you kind of want to see like central scar, dilated glands that are really close to that centralitis, and then everything just radiates out. It's like they call them coronal sections, or like meaning crowns, so they just go around. And again, these are common lesions, and they've actually found that from doing a lot of autopsy studies, so older women. So who knows the incidence in like women just walking around on the street. But it is important to note that it's not associated with trauma, surgery, or injury to the breast, like I mentioned before. Most of these are incidental, so they're looking for calcs, and then they get a radial scar. And once they have a radial scar, then they have to go back and take it out. And why? Because they tend to have angulated lesions. They can be associated with anything, so we want to make sure that there's not some invasive carcinoma just sitting around on the outskirts. And usually if that happened, it's not, there's a radial scar and it becomes carcinoma. It's probably like there was a radial scar and carcinoma starts encompassing a radial scar, okay? Because even though we see PIK3CA in, I think it was like 62%, something like that, cases, when we have concurrent carcinoma in the patient, even if they have a PIK3CA mutation, it's a different variant. So that just kind of tells you like they're not along the same wavelengths. What else? That's a very nice gross photo of a radial scar. And 6% lifetime risk. So again, it's in that 5 to 7% or 1 to 2 times risk. So it's really not increasing our risk too much. And because of how it likes to angulate glands, we're looking at, is this an invasive carcinoma, or are we looking at a tubular carcinomas? Okay. Hyperplastic. Okay, so no slide. They did not have a slide. That was just UDH. So I just wanted to give you guys a little bit of information about UDH so you can review this on your own time. I really like the couple of graphics that ExpertPath had on their site, because I feel like it gives you a better mental picture of what UDH can be, because from, like when you're thinking UDH, like we always think like those slit-like spaces on the outside, and then you start seeing, oh, there's some like sort of punched out areas in the middle of the lesion. Is this now ADH? What do I do? And pretty much it's like if UDH still looks like nobody looks like their neighbor and they're all piled up on top of each other like they were playing football or something like that, then you're dealing with UDH. So there's different patterns. All those patterns are associated with florid UDH, which is what we see more commonly. Okay. And then you can see your nice keratin stain there. Again, they have that 5 to 7% risk of invasive carcinoma. And look, our friend PIK3CA is back, and there's also rare cases that have loss of heterozygosity. But pretty much we're not seeing anything that is definite for our low risk lesions. And they don't have to do anything with this. One other thing that I'm sure I put on the previous slide, let's just make sure that's on there. Yes, I do have that on there. So I have a picture of central necrosis there, so don't let that scare you, because if nothing else looks like DCIS and you have that tiny little bit of central necrosis, that's okay. You can have that in UDH. Okay. All right.
Again, breast tissue. This one's mostly fatty. We have some population of ducts here, which we'll take a better look at. Seems to be not really any ducts here. So let's take a look. So there is a proliferation just looking at this. The lesions, at this power, it looks a little punched out. Kind of smooth borders, not really jagged. This one maybe you could argue is a little more jagged. Looking around here. So from these cells over here, I mean the first impression that's kind of punched out. The cells don't look like there's a mix. They look kind of similar to one another.
Yeah.
And they don't really look like they're piled on top of each other as much you would expect from UDH. And in general, it just doesn't look as bad as a UDH. And so I'm thinking probably it's an ADH. ADHs never really look as nasty as UDH, which is the irony of breasts.
Exactly.
And something that, starting on breasts is something you need to just hammer in, like ADH looks a lot better than UDH.
Yeah, it does.
So, I mean, compared to the example shown in the previous one, this one doesn't look that bad. And maybe at low power you could appreciate it more than high power on this thing.
Mm-hmm.
because at this power you're like, okay, well, this looks pretty round and punched out looking, and the cells around it not sticking. So I would go with final answer ADH.
UADH.
UADH, ADH, ADH final answer.
I like that final
Okay.
answer. It's a great final answer. Okay, so we still see a lot of this, and again, they had a really nice schematic for ADH, where it's like you can kind of see, all right, we're starting to see more of a Swiss cheese effect, and you'll have, instead of having 3, 4, 5 cells in between all the spaces, you're going to have 1 or 2, and they're more well defined. So what we can see down below on the histology section is that, we have more of those punched out spaces. There's a little more space in between all the cells, and it kind of just looks like it's the same cell over and over again, which you pointed out, that kind of terrifies us in breast. So what shouldn't we see? Well, we shouldn't see any high-grade atypia, and we don't really see necrosis with ADH or mucin production. We can see calcifications, right? Because usually they're trying to get a lesion that has a lot of calcifications, and this is what you get. Obviously in association with other breast lesions, so we were having a debate about UDH. And if you have ADH and you haven't completely submitted the specimen, guess what you get to go do? If that's the worst thing you have, you get to go back and submit more or all of it. And the reason for that is because there's this, debate of the ages for when do you call DCIS versus ADH, and basically nobody can agree. They still can't agree. Like different authorities will call different things. Yeah. So
It's
is
one-
it
one of the
more than
states.
2 focuses? Is it more than 2 millimeters? Is it, so everyone, like, well, I shouldn't say everyone, but usually like institution to institution, they'll have a threshold that everyone is at. So as long as you're sticking with that, that should be okay. Okay, so what are they going to do? Well, if you have a biopsy and you have ADH, they're going to go back and they're going to do an excision because they want to make sure it's not DCIS and it's not an invasive process. If they want to be maybe a little more conservative, they could put the patient on tamoxifen and really tap down their estrogens. A lot of patients will also opt for just surveillance. So we do see the difference though, is that our prognosis is no longer 5 to 7%, right? It's 13 to 17% lifetime risk. I should have pointed out too that all these lifetime risks are for bilateral breasts, and over the entire length of a person's life. One other thing to point out is the molecular. So the pairing of gain of 1Q and a loss of 16Q, this is your low risk lesions. So if you have a lesion that has that, then start thinking low risk. If you were like, this looks like UDH, well, UDH probably shouldn't have that, so let's go back and think what else it could be, okay? And a lot more pictures of ADH because ADH versus UDH gets really confusing sometimes, and especially if you go into papillary lesions that have atypia, and you're like, oh my gosh, what do I do with this? And hopefully we'll have some examples when we do papillary lesions. Fingers crossed. Okay, and our last lesion of the day.
What?
Very posse.
It looks like there's nothing here.
Posse ductal.
Yeah, healthy ductal. Right here, there's some micropapillary structure. Here, some snots.
Okay.
I don't know what I should say about that. There are some pretty dilated ducts here. It looks very benign.
I agree.
Here starts to be anonymous a little bit. I didn't see much atypia. So columnar cell change at most for that.
Most, okay.
Yeah, I think nothing worse than that. Okay, here.
Oh, that's good, cause we like to write our laundry list. Like I see ADH, FEA, calcs.
Those ones are a little more concerning,
Yeah.
but it could be just like tangentially cut.
Here, like, disrupted. I don't know.
Hey, what about those?
Yeah.
I mean, assuming they're not tangentially cut.
Right. Let's give them the benefit of the doubt and say it's not tangential. I don't actually know, but like okay, yeah, there's some microcysts, there's some columnar cell change. You could argue that there's a bit of columnar cell hyperplasia.
Yeah, that's what I want to say about this.
Okay, keep looking.
I mean,
'Cause I just showed you ADH, right? So where do you think I'm going next?
ALH.
ALH, right?
Yeah, I was looking for that.
And I think it's like a really small area.
A very small area. This looks okay. This looks okay.
Okay, but you keep going to the cystic areas. Is it ALH cystic?
No, it should be a small cluster of
Yeah.
glands.
Excellent. There, see, you guys don't even need me up here. You know all this stuff.
Just where it is? Here? No, it looks very innocent.
No.
Could this be? No.
No.
It doesn't
I mean,
look
so
like.
far the only thing that's most convincing for that, which is that little
Is this?
cluster we were at
Which
earlier.
might be LSO.
That's why,
But,
Yeah,
okay, compared to
assuming
our
these are-
normal, okay, so compared to our normal, what's the definition of ALH?
It's just a little bit expansion of the lobules.
So I was looking more discohesive.
Yeah.
Yeah, you're right. you're
Okay,
right.
so yeah, I feel better. Okay, I'm not crazy. At least know about that,
I
right?
mean, it's assuming that's like not a, you know.
Right, right. But
That's the
okay,
best
so
guess.
this is a perfect view. So you see, we have our normal up there, right?
Yeah.
And you compare it to this. This is expanded. You guys don't get to argue with me that that's not expanded. Okay, so there's your lesion and ALH because you guys know I go in patterns. Okay, I know, not great, but most of what I have for you is high power focuses to try and convince you a little bit. So we don't see too much of this, and often they have calc somewhere, and then they take a biopsy, and they're like, oh my gosh, there's ALH, or we'll use the term now, lobular neoplasia, right? Because what's the difference between ALH and LCIS? And it goes back to the DCIS, ADH, how much is too much? Well, that slide, that was ALH because I don't think I know anyone who would be comfortable calling that LCIS because it's way, way, way too small. Okay, but pretty much we have non-scary nuclei that have, typically will have intracytoplasmic illumina, not always. So they could have like a signet cell look to them. They're loosely cohesive, so what does that mean? So if there were areas where they looked more cystic, it would be like falling apart. They don't have well-defined borders like we see in ADH. And you tend to get some distension of your acini, but overall your lobular architecture is going to remain intact. Whereas with ADH and UDH, you can get like that really like gargantuan expansion of things. So you're not going to see that in ALH and LCIS. What else? I do have a little inset on the top right there of the cloverleaf pattern. So pretty much that just means like it starts these little outshoots, and because of the dilation, you get like this cloverleaf look to the ducts. Okay, so for stains, your E-cadherin is going to be negative. So the caveat to that, though, is that your myoepithelial layer is still present, and it is going to show patchy positivity for E-cadherin because expresses peak adherent. Other things like your high molecular weight keratins, so like a lot of our other lesions that were positive for low molecular weight keratins, so sometimes that can help you. The molecular, so the loss of 16q21 to q23.1, so that's your EK-adherent gene, and that makes sense because if that's lost, then obviously there's some aberration there. But there's a lot of other things that they found, like whether it's the AKT1 gene or loss of heterozygosity. So there's a lot of non-specific molecular findings for ALH. So things that they can offer the patient is like risk-reducing surgery. Well, if they're going to do risk-reducing surgery, that means they're going to do bilateral mastectomies. Not a lot of patients want to go for that. Okay, well they could do like 5-10 years of tamoxifen with all its side effects, and a lot of patients don't want to do that either. So often with ALH, patients will go on surveillance, and like, you know, if we do an excisional biopsy and that's okay, then maybe I'll go on surveillance and I'll just go see my doctor and get imaging done once or twice a year. And similar to ADH, our lifetime risk of invasive breast carcinoma in either breast is 13 to 17%. So it's still higher than our more benign lesions, but it's still not crazy high. Okay, so that's what I have for you guys. So, challenge cases, 10 cases. So that should kind of give you an idea of how much pickings I had to choose from for this lecture. So most of the things are things that we went over in the lecture. I think there's 1 or 2 cases that are a little different. And there's one where, you know, you can tell me, oh, I went this way versus that way. But all those are just up there for you guys to take a look at. I have updated the email that I send out to you guys, so we'll have the presentation on there, including the Twitter handle, and I also put on there it's still the KL slide review for the YouTube channel, but I can put a link on that email as well for you guys if you think that would be helpful.
Mm-hmm.